Yeah, first of all, I would like to welcome you all to our webinar on public palliative care education. Thanks to everyone for attending. There are many more people coming in, but we're just starting. And as I said before, I would really love to welcome everybody from around the world on behalf of the EAPC and the EAPC Task Force on Last Aid and Public Palliative Care Education. I will just start to give you a short overview. Oops, no, sorry. Yeah, we have a seminar. We have 4 speakers. I would just like to introduce you shortly to the task force before we come into the speakers. And the task force is chaired by me. My name is Georg Bollig, and I'm a senior consultant in palliative medicine at the University Hospital of Southern Denmark in Sønderborg. And I'm a clinical associate professor in palliative care at the University of Southern Denmark. And I would like to invite the other 2 chairs to welcome you. So Marius, I hand over to you.
Good day, everybody. It's real lovely to be speaking in this lovely audience today. So I'm Marius Ciurlionis. I'm from Lithuania, and I'm currently working at the Ministry of Health, coordinating a long-term care provision in Lithuania. Thank you so much.
Yeah, thanks, Marius. Boris.
Yeah, well, welcome from Frankfurt in Germany. My name is Boris Knopf. I'm a palliative care nurse by training, leader of a palliative care home-based service here in Frankfurt, and a children palliative care service home-based in the area of Southern Hessen. I'm really happy and glad to be here supporting the idea of the EAPC, the Task Force for Last Aid and Public Care Education. I'm really happy and glad to be with you, and it's nice to see so many people from all over the world. This is really fantastic.
Yeah, thank you, Boris. And yeah, I showed you that, and here you can see a list of the members of the task force, and it's a call for action too, because if you're interested to join our forces and work with us together in the task force, just contact me. So our work has been hampered, as the work of most people, due to COVID in the last 2 years, but we are still working with the topic, and we'll come back to that. Yeah, background for the seminar, background for public palliative care education is this question here: where do you want to die? And if you usually ask people, most of them would say they would like to die at home. But if we look at the numbers throughout Europe, we know it's about 70 or 80 or more than 80% of the people who say they would like to die at home. But if you look at the reality, it's usually about 20%. So this was one of the background reasons why we started public palliative care education. And you probably know Alan Kelleher. He has reminded us that end-of-life care is everyone's responsibility. So it's not just the professionals, it's all of us, everybody. And we think that last aid courses may form the educational basis of compassionate communities. Yeah, but what is public palliative care education about? So the aims of public palliative care education are to educate the public, obviously, but also to empower citizens to participate in end-of-life care. So that they think they can do it, and that they feel okay doing it. And last but not least, it's also about enhancing the public discourse about death and dying, because it's still like that death and dying is a taboo. And we think public palliative care education is a key to starting community action and to achieving community participation. And if one looks at the literature, you can see there are different models that has been used, that are currently being used. For example, the Death Chat at St. Christopher's in London. There have been psychosocial education group models, for example, from Australia, but there has also been the use of the internet in massive open online courses, for example, from Australia. Some people know death cafes. They have been started in 76 countries. And since 2015, we have last aid courses. And after the pandemic started, we also had online last aid courses, which are now being held in 20 countries. So we are coming back to that. So we think it's really important to educate the public and you will hear the 4 speakers later about that. So the last aid course concept was started some years ago. The first idea was described by me in 2008, but in the real world, they started first in 2015, and they were inspired by first aid courses and especially by the very first short courses from Seattle. So I will just show you a short video about it.
Mein Name ist Barbara Adden. Ich habe letztes Jahr meine schwer krebskranke Freundin für ein Jahr durch ihre Krankheit begleitet. Meine Freundin war schon auf Palliativ und ich brauchte Handwerkszeug und habe das im Internet gefunden, diesen Kurs, und war ganz begeistert, dass ich da eventuell was finden könnte, was mich stärkt. Und habe da angerufen und hatte super Glück, dass ich innerhalb von einem Tag nachrücken konnte. Und das war das Beste, was mir passieren konnte.
Letzte-Hilfe-Kurse wurden entwickelt, um Menschen aus der Bevölkerung wieder an diese Themen Sterben und Tod heranzuführen. Das ist uns in unserer Gesellschaft leider ein bisschen verloren gegangen. Und wir wollen mit unseren Kursen daran erinnern und die Menschen wieder mit diesen Themen in Begegnung bringen.
Das ist was Emotionales, auch. Auf jeden Fall.
Der Letzte-Hilfe-Kurs besteht aus 4 Modulen. Sterben ist ein Teil des Lebens, Vorsorgen und Entscheiden, Leiden lindern und Abschied nehmen. Und jedes Modul dauert 45 Minuten.
Der Aufbau war schon so, dass man erstmal so seine Aufregung irgendwo lassen konnte, und die anderen hatten ähnliche Erlebnisse oder wollten sich vorsorglich erkundigen, was ich auch gut fand.
Der Letzte-Hilfe-Kurs richtet sich an alle Menschen. Da geht es um keinen beruflichen Hintergrund. Das kann ein Automechaniker machen, jemand, der im Büro sitzt. Das können auch Pflegende machen, aber grundsätzlich jeder Bürger.
Ebenso wie in Erste-Hilfe-Kursen bieten wir mit den Letzte-Hilfe-Kursen eine Basisqualifikation für die Bürger und Bürgerinnen an und damit ein Allgemeinwissen, das auch schon in den Schulen gelehrt werden sollte.
Und der ganzheitliche Ansatz, das haben wir da schon, also wir betrachten den Menschen nicht nur rein körperlich.
Der Kurs ist wichtig für unsere Gesellschaft, weil wir eben mehr alte Menschen bekommen werden, mehr pflegebedürftige Menschen. Deswegen brauchen wir die Bürger, also es braucht bürgerschaftliches Engagement, es braucht jeden Einzelnen, der mithilft.
Lernen, wie man den Menschen vielleicht ein bisschen Hilfestellung geben kann und denen noch ein paar Tipps geben kann.
Und das ganze System wird halt von Ehrenamtlichkeit getragen.
Am meisten hat mir geholfen im Nachhinein, wenn ich das so Revue passieren lasse, die Handreichung und was man alles tun kann, was einem so erstmal gar nicht in den Kopf kommt, weil das sehr normal war und nicht so was Extravagantes oder dass man dafür medizinisch vorgebildet sein musste, sondern tatsächlich als normaler Mensch die Mundpflege machen kann, darauf achten, was der Mensch sagen möchte, wie es ihm gerade geht, wie er atmet. Und das war ein gutes Gerüst.
Das Sterben und der Tod und die Trauer sind immer noch Tabuthemen in unserer Gesellschaft. Und am häufigsten als Feedback höre ich von den Menschen, dass sie sich bestärkt fühlen und auch erleichtert fühlen, dass sie eben über diese Themen sprechen konnten.
Ich konnte sehr gut mit meiner Freundin drüber reden. Sie hat gemerkt, dass ich gestärkt war. Und das war eine ganz wertvolle Erfahrung für mich, weil wir uns getraut haben, tiefere Gespräche zu machen und Themen anzusprechen, die man vielleicht weglassen würde. Und dazu gehörte einfach auch die Vorbereitung auf den Tod. Ich würde diesen Kurs vielen anderen Menschen gerne empfehlen, als einen Schatz sozusagen bei sich zu tragen, weil der so wertvoll ist.
Yeah, this was just a very short introduction into public palliative care education and what last aid courses are about. And we have now 4 speakers. Just a short information for you. If you have any questions, just write them in the chat. So then we will have 5 minutes allocated after each presentation. We have 4 presentations with 15 minutes each and 5 minutes for questions. So we are watching the chat. Just put your questions in the chat. Okay, and the very first speaker is Marius Ciurlionis, one of our steering committee members. and he's going to tell us a bit about mapping education needs of family members in Lithuania. Please, Boris. Please, Marius, excuse me.
Thank you so much. Great. I'm just trying to share my slides. I think you should be able to see it. Yes, so mapping the educations of family members in Lithuania. So currently I'm working in the Ministry of Health, as I mentioned, and last week we had a meeting together with people from OECD, and we're talking about tools that we could implement in Lithuania in order to find what is the actual need to educate the family members. What we are experiencing here in Lithuania, and I think it's common for all countries all over the world, that we are lacking healthcare professionals, both physicians and nurses, and they are key members in providing palliative care to our patients. And what we discussed that before starting to inventing a tool that could help us to educate our family caregivers, we need to map education needs, and we need to know exactly what people are looking for and what our abilities to provide the information they are looking for. And I'm happy to announce that this work has started way earlier, almost a year ago, together with a regional healthcare provider in Vilnius area. That is the biggest area in Lithuania. We started exploring what are actually needs in this current area. Of course, as it is heavily urbanized area, it does not present the country, but we can have some projections and try to understand at least social and cultural factors that affect education needs in our country. So basically, I'm going to be talking about the survey a little bit later, but palliative care in Lithuania is a really newborn child because it started only in 2007. It was the first legislation that was established, and in that legislation we're talking about how palliative care should be provided in hospitals and in home care. Later on, the legislation has changed, and daycare was involved. New team members were implemented. So today we have a home care, and we have a network of home care providers all over Lithuania. Also, we have some daycare centers, and I think this is what we are lacking the most, because we overall have 60 municipalities, but only 17 daycare centers. So our initial goal is to have daycare in every single municipality. And of course, institutional care, and I think this is where we are doing kind of okay. Because in Lithuania, we do not have many hospices. We have only 3 hospices, but institutional palliative care is provided in nursing homes. And we have a network of nursing homes in every single municipality, and in every single nursing home, you will going to be able to find at least 2 or 3 palliative care beds. And it kind of gives you a community approach, whether you have palliative diagnosis, and if home care is not sufficient for you, or you need more services, so you don't need to leave for another municipality, and you can have the service provided quite near where you live. And if you remember the question that Georg asked, where you would like to die, and very often people answer they want to die at home. And we had this case when one old lady, she was placed in nursing home, and she was able to see her house from palliative care unit, and it was the same as being home. Another thing that we were working on it is palliative care teams. So in Lithuania, palliative care team consists of nursing assistant, physician, and psychologist, medical psychologist. There are coming new changes in our legislation, and what we see that there is a great need for physiotherapists, and we hope that from the beginning of 2023, we're going to be able to provide or include in our teams physician as well. So community approach is our goal, and we're talking with the municipalities, with mayors and administrators, because they know their society, they know the people living in the municipality, and they know what are the best approach, because what is common from heavily urbanized area may be slightly different from what is the area where mostly are only villages. So this is a picture of 1 hour hospices, but there are new changes coming in our legislation. And what we lacked in Lithuania, this is communication between the hospitals and home care providers. So very often what happens, a person is being discharged and have only epicrizis and is being sent home. And then the person needs to approach family physician just to learn more about palliative care that could be provided in their homes. We also are establishing a specialized palliative care course for all the physicians, nurses, and nursing assistant and other team members that will provide palliative care. It was a general course before, but now we're going to have it specialized, and with spending 4 hours trying to educate the healthcare professionals how to educate family members. So, and it will also establish a new form of impairment where there should be a communication between the hospitals, home care provision, and day care. So, at the beginning, we were trying to understand our social and cultural behavior. It is very common in Lithuania that family members are trying to look after their loved ones, and very often the healthcare institution is the last point where they turn to. Very often healthcare services are left apart, and persons who are caring for their loved ones are trying to provide palliative care with their own capabilities. And it gives us a lot of information that there is a great need of education in palliative care. So what we are doing currently, so we are doing the survey of 50 nurses that are providing palliative care in community settings, and we are trying to explore 350 palliative care patients that are receiving home care. We're trying to identify what are the greatest challenges they're experiencing, and what people and their family members lacking knowledge about the social services, or how to provide healthcare, or how to prepare for dying, what to do after a person has died, where should we call, and what should we do. So what we learned so far, the key is knowing your society, and once you know your society, you can look at those existing educational tools, and it is way easier to approach the people, the citizens. So this is actually the network of Lithuanian palliative care home providers. We definitely have quite a lot in Lithuania. We have in every single municipality, and it happened due to the law that came out in 2020, and it is mandatory for all primary care providers. It doesn't matter if it's private or public, to have a contract with palliative care team. So it enables that every single person, doesn't matter where his or her GP is, could receive a palliative care. And knowing this network, both in urban areas and villages, allows us easily to approach our palliative care users and easily to understand what are educational needs and how can we involve them in education and process. So what is next, perhaps, is another question. So how to approach the communities. So once we're finished with our mapping, perhaps we're going to take a second round and trying to find the matching tool for the educational platform. We'd like to build a national education platform that could involve both volunteers and healthcare professionals, as well as other community members who were involved in palliative care or are willing to be a part of palliative care provision in the community. So perhaps there is not a single education model that exists currently, but we are looking at the neighbor countries. So we are looking quite closely to our neighbors in Scandinavia. How are they dealing with? We are really interested in a model that was developed by the Norwegians in their communities. And our main goal is to involve both family caregivers and non-family caregivers. And what we noticed from the first interviews with family members, that very often they do not think about palliative care before they interact with the actual illness of their relative or their loved one. So we think that perhaps the best approach would be involving healthcare professionals that are working in the community. We'd like to have academia or universities working together hand in hand with healthcare professionals. And in Lithuania, we have last 8. We had this course, and we have now 9 teams that are tutoring our society. I have to admit that pandemia has heavily impacted the courses. However, we have 4 teams, it is almost 40%, that are still working quite hard, trying to introduce the society, talk to the students, talk to the people, so in the hospitals, arrange meetings, to teach them what is the last aid, how it is provided, and what is use of it. So although pandemia doesn't allow us to meet in person yet, but we were able to launch several online sessions, but still it is not the same as seeing everybody in flesh and talking and trying to experience, trying to feel each other's emotions. And it's definitely not that open as it was previously. But we hope that very shortly coronavirus is going to go away and we're going to be able to continue, because people are coming back from the courses, from the last 8 courses, give the most positive feedback, and they definitely are happy. Of course, the majority of those who are attending courses in Lithuania are whether healthcare professionals or those who are already involved with somebody who is ill in their surroundings. So there is a great need for education of society, especially in Lithuania, where palliative care is expanding and it's brand new thing. And usually it was a lot of stigmas regarding the dying and burdens that family caregivers were trying to bear on their shoulders. So what we see that educational platforms gives to people who are providing palliative care, free mind of thinking. They know what to expect. They know how they can be involved. They know who to call when the emergency strikes. So I think last 8 did a really great job already in Lithuania, and it continues doing it. So this is short presentation for me. I think it was exactly 14 minutes and 30 seconds. So if you have any questions, go ahead.
Yes, Marius, we have some questions. Maybe the first from the chat. Would you like to guide me? Is there any nursing program, PhD nursing program especially in palliative care?
No, we don't have specialized programs for nurses or physicians, but what we have in Lithuania, it's mandatory 36 hours course for every single team member who is providing palliative care, and it has several components. It consists of physical needs, pain management, psychological needs, approaching death and dying. So these are the common components of the courses.
Mm-hmm. Then we have another 2 questions. One is very short. Hi, is it an outpatient hospice or inpatient hospice? You spoke about hospice.
Yes, so we have only 3 hospices. The one is providing outpatient services and inpatient services. All of 3 providing inpatient services, but only one is providing outpatient services as well.
Mm-hmm. And then the last question, do you think that the palliative care education curriculum requires our overhaul, given the fact that there has been a definitive movement towards enhanced supportive care, patient-centered care, as definition by the ASMO paper?
Yeah. So I think what our society is experiencing right now, and what we see, I think is the biggest problem that we are having currently, that we have a great shortage of our healthcare professionals. And without approaching non-healthcare professionals and reaching the concept of what we are aiming to do and where we are heading, it is impossible to have great outcomes. The quality should be standard number 1, and I think this is where we should head to.
Mm-hmm. So in one way, it should be some renovation and optimizing the education programs.
Of course, there is always a great need, because we are living in the society where everything is changing, right? And telemedicine is approaching quite heavily our let's say typical palliative care provision, and I think updates are always needed.
And another question we have: when you talk about education of the public about palliative care, are you referring the education about last months, weeks, or of life, or early palliative care support?
Oh, we start with early palliative care. Once person has been diagnosed with a terminal illness, it could last 2 years, it could last a few weeks, but I think it doesn't matter when you hear the diagnosis. Everybody go through the same processes, and family caregivers have the same experiences. So the earlier you start, so the better preparation you have, and perhaps both physically and psychologically.
Thank you, Marius. That was all.
Thank you so much.
Yeah, thank you very much for your presentation, Marius, and answering all the questions. Yeah, next point on our list is lecture coming now. Just a second. So now Erika and I am going to give you a short introduction to last 8 research results and the large research group. And probably at the very start, Erika, you should introduce yourself a bit.
Yeah. Hi, I'm Erika Zelko. I'm coming from Slovenia, and we're leading also the last 8 movement. but currently I'm working in Linz, and the University of Linz, where I'm leading the Department of Family Medicine. So I'm working in the education, research, and also partly a GP, but only 10 hours now in Austria. In Slovenia, I was working fully in the general practitioner practice and in palliative medicine in primary care level.
Yeah, thank you, Erika. And Erika and I are chairs of the large research group, which I want to hear about in some seconds. You saw a short video about the last aid course and what it is about. So just to summarize it in short, it's a course very similar to a first aid course. It's a course for everyone. So it's also for children, and we have started to have special courses for children from the 8 years age. Usually it's held in a classroom setting with 6 to 20 participants, and it is held by 2 certified instructors. And one of the instructors usually is a physician or a nurse. So they are highly specialized people, but they're also volunteers. And it's always a pair of instructors, showing also that palliative care is teamwork. And to make it short, we did 4 modules with 45 minutes each. And the modules are about dying as a normal part of life. It's about planning ahead, including advanced care planning and making decisions. And it's obviously about relieving suffering, which we also call practical last aid. And the 4th one is about final goodbyes, where we're talking about burial and bereavement and such things. And basically the courses are the same in all the participating countries, besides, of course, national legislation in terms of advanced care planning or organization of services. Yeah, you can find a review on all the last aid research, which has been done from 2015 to 2021 in a paper that Ethna Hayes-Bauer and me have published in 2021. And I just want to give you a short introduction to some of the papers which are in there. So the very first paper on the last aid course was done in Germany. Sorry for now, just have to minimize this. Yeah, sorry. So the very first paper was already with the first aid courses, which were done here in Schleswig, where I'm living. We started also research. So we started to give the people a questionnaire and ask them, what do you think about the course? And we wanted to investigate, is the course feasible? And we saw the course was feasible, and it was very well accepted by all the participants. As you see in the pilot study, 100% would recommend the course to others. So it really worked. We have also tested courses for children, which we started in 2018. And it was really interesting to see that 85% of the participating children stated that they have had previous experience with death and dying. We didn't ask if that was in the family or another place, but it's really interesting that most of the children state they have experience, and they really love to talk about death and dying. So of the children, 95% found the course useful for everyone, and 92% would recommend it to others. Yeah, another thing which a group did in Freiburg at the university hospital was that we did last aid courses for all the employees, including technical personnel and non-medical personnel. And there it was clear that people really liked the courses. But on the other hand, we had some people from the medical staff who said they would like to have an extended course curriculum. They would like to learn more about palliative care. But interestingly, there are many people from the healthcare professionals participating in last aid courses for the public. We have done a multi-center study in 3 countries, in Austria, Germany, and Switzerland, where we had included more than 6,000 people. So we had a return rate of 91% for a questionnaire. And in this multi-center study, we could see that the median age of the participants was 56 years and 88% were female. So there are many people participating in the last aid course who are actually taking care for others or who are thinking about taking care for others. Again, here in this big sample, 99% would recommend the course to others. So it looks like the course really fits what people would love to learn about last aid and death and dying. So there we have shown that it is feasible in different countries. You can see the picture here. You can see it was people participating were from 15 years of age to 94 years of age. And we had actually the oldest participant I know about was 100 years old. And when we asked her why she would take why she took the course, so she answered because her friends were dying and she had to help her friends. So yeah, it works. People talk about death and dying during the course, and people are really encouraged to talk about death and dying after the course. And many state that they want to participate in end-of-life care afterwards. Yeah, and you all know at one point in time, COVID started and there was no more classroom teaching. There were no scientific conferences. And we asked us, how can we sustain that? What shall we do? And some people suggested, okay, let's do last aid courses online. And we heard it from Marius. It's really a problem that people cannot attend courses. So we had a working group of experienced instructors who created an online last aid course, and which we used in Germany in 2020. And I was a bit surprised when I saw that people really loved the course. It was also different groups attending the course. So we had more people attending the course who were actually in a caring role, and they stated they preferred an online course because they didn't have to leave their home. So that is very interesting. And another thing was that, of course, younger people who really love the internet were participating more. So people really encouraged us that we should stay with online courses also in the future, because some people really prefer it. That was kind of astonishing for me, but most prefer the classroom, but some prefer online courses too. So you can see we have also had a paper on that. So most people thought it was the second best choice. And this is the same for the instructors and the participants, but there are still some people loving online courses. Yeah, and of course, in 2020, we had planned the second International Last Aid Conference in Maribor. And yeah, we couldn't do it in Maribor, of course, and we switched it to an online format. And what we learned there, what it was really interesting, I think it's the same what we see today, that many people from around the world are able to attend a meeting if it's online. So it also has advantages to do things online. Yeah, and if we look back to in the recent years, we can say last aid started at one point in time. In 2014, we had a working group. In 2015, we had the first courses here in Germany, in Denmark, and in Norway. And afterwards, I did a EUPCA project, a project of the European Palliative Care Academy, where I aimed to establish an international working group on last aid with at least participation of 6 to 10 countries. And if we're looking at where are we standing now, is we already have included 20 countries in the working group, and the work has expanded far beyond Europe. So we have now Brazil with us, we have Canada, we have Australia. So it spreads around the world. Here you can see a short overview about the 20 countries participating. So it's, yeah. And then I would like to hand over to Erika in order to talk a bit about the Large Aid Research Group. Please, Erika.
Yeah, thank you, George. We have some questions already, so please be prepared. When we talk about research, it's really important part of education of the community, and also about the development of palliative care. Why? Like already Marius said, we should know what the community needs, the family members, because we have in the community really big differences, not only cultural differences, but also the diversity in the community needs sometimes some different approach. So, for example, in Slovenia, we saw that we have quite a huge population of interested deaf peoples, and they were really happy when we prepared the webinar in last aid for deaf people with the sign language. Then when we came together, different countries, we really quickly realized that some questionnaires should be adapted for the assessment of the course of last aid, because with this possibility we could look for better quality of the educational materials. So we start with refreshment of the questionnaire last aid for the participants. Now we think also about mapping the education needs in the community education needs in palliative care. And we also think that it's really would be interesting to see if in different settings the last aid course must be adapted or maybe upgrade with some other topics. And before I go further, George, maybe one or two questions to these topics already. I'm from Nepal, and I also like to create awareness about in public. So could I get permission to use this course model in Nepal?
Yeah, I would just say contact us, because we have Last Aid International, and usually it's like that we have a partnering organization in the different countries. So it was just take contact with me, and then we can talk about it. Usually we have a partnering organization, and this can be very different. This is, for example, in Switzerland, it's the church. In Scotland, it's the Highland Hospice in Inverness. Different organizations in every country.
For example, in Slovenia, we have the Institute of the Medical Faculty in Marius as a leading partner. Another question, very interesting course. It's a course offered freely, and was it easy to recruit children?
Yeah, also my aim was that the course should be free for the public, but I've been asked many times if people could charge them, because they have costs for the room or for other things. So we do have some international course rules that the instructors or facilitators, how we call them, have to adhere to there. So there is the possibility to charge an amount up to 20 euros for a course participant. And the other thing was about the children you asked. So I must say,
was it easy to recruit children?
Yeah, usually it's really easy to recruit children, because children are very interested in the topic. It's more complicated to talk to parents or to talk to teachers. And at present, we do have a thing in Germany called Start Social, which is a kind of competition for social organizations. And there we are really looking at how can we inform the public more about these courses, and how can we engage teachers in the work, because we see it's usually the adults who are reluctant to talk about death and dying. And of course, the teachers are adults. So we have to get into the schools, and we're really trying to reach out also to politicians to get this done. But the children are really interested.
The online courses work really well in Scotland, Slovenia, Switzerland, Indonesia. But then we have a comment, please keep me informed of development of delivering last aid in England. From Transylvania University, Brasov, we have a master degree program in palliative care specialty. And then from UK, we have also a comment. I hope we have available online courses. Then, there is one. Hi, Kate, Pete from Lancaster. Compassionate Communities UK are interested in helping with last aid in England, and several people wish me to train. Finding funding has been the restraining factor in England. So
yeah, I can probably comment on that, because we have been trying to get this to England for a long time, but we do need a partnering organization in England too. So that has been a problem, and finding funding there. So.
Then we have also one comment. We have the International Observatory in End of Life Care at Lancaster University offers a learning PhD program that are suitable for health and social care professionals. Maybe the answer of the last question. So, there has been a talk about assessing the needs of community. Have developed questionnaires or any already existing? Marius? we don't have the questionnaire for assessing the needs of the community. We have developed the questionnaire or refreshed the questionnaire for the participants. They already attend the last aid course. So we try to find a tool, but it should be special in the palliative care. You know, we couldn't use every questionnaire because some of them already they are here. They would like to assess some different topics in public health care, and maybe we could adapt some of the questionnaire also for the palliative care. Any research working in the last aid course in Africa? George, do you know something about that?
Not yet, I would say. So we would love to. So, but we're expanding. But Africa is not yet part of it. So.
In France, the National Palliative Care Organization, SFAP, got the license. We are launching last aid this year and are very excited. Okay.
Yeah, France is just about to start. So and it's very different. We have countries who have been with us since 2016 or 17, and some are just launching. So welcome, France.
Very interesting course, simple and effective. Have you noticed if the course increased advanced care planning?
No, we would love to. It's really and this is a comment on the large research group. One must say, so far we know what the people think about the course, and we have no long-term outcomes. What we are doing now, what we have done already, is that we have established an international last aid course questionnaire, which people can use after the course, and we will in the future ask the people if we can go back to them, calling them by phone or giving them an email half a year or 2 years after the course in order to approach these long-term effects. So we don't know very much about the long-term effects. We have a case study which will be published soon, where we have some cases of people who have contacted us, so who have visited a last aid course and then have cared for other people and have given their feedback afterwards. So we do know that some people really appreciate the course and think it empowers people to do things. Another thing we see in the research is that some people attend the last aid course after having been engaged in end-of-life care in terms of to hear, have I done it right? So that is really interesting. And usually the people see, okay, I have done it right. But other people, of course, see also, oh, I should have known that before. So it's very different. And in general, I again would say it's like a first aid course. Everybody has to do a first aid course. Don't wait until you see a traffic accident. So I guess Marius has a question. Boris has a question. So.
Yeah, just to get a side effect, because the question of advanced care planning. So it's different from the countries. The most last aid courses already I have held were in German. So in Germany, the movement of advanced care planning is on a very low level. It's starting now, getting bigger and bigger, because it's in the elderly homes existing for a special program. But I guess it's more in the start. So last aid is more than a movement, and it has different aspects we could need. So there's also last aid for children, and there also will be last aid for professionals, because we also have many people working in the healthcare system are not really knowing much about palliative care, and it's more about getting this movement done. That's the side effect.
Yeah, that was what we learned in the study from Freiburg, that we were people for healthcare practitioners who wanted to know more. But if you look at the numbers, you could see there's almost about a 10% of the participant of last aid courses coming from healthcare professions. And I think this is astonishing, because they should know. So, but they are still interested.
George, we have one interesting question now. After the course is undertaken by community members, has there been any program service development that have come out of particular needs addressed by communities around palliative care? I could answer this question only for our country in Slovenia. Yes, we have met one small project with the students, nursing, medical students, and students working on the social gerontology department and prepared some information leaflet and also some website together with the Hospice movement in Slovenia. That was the results from last aid assessment of the last aid program. So it was really interesting. Without this program, we didn't know that we need this information sets. George, could you add something?
Yeah, no, I think you have told what is really important. I think we should go on because it's a really interesting topic and we could talk hours about it, but I think we should go on, and we have some time left if people have unanswered questions. I will be happy to answer them at the end of the session, but I think we should go on with the program, and I would like to introduce Mark Hazelwood, the CEO of the Scottish Partnership for Palliative Care, and you are giving us an overview of end-of-life skills for everyone, EASE. Please, Mark.
Thanks, George. Thanks very much for the invitation to share our experiences in Scotland with, as you say, end-of-life aid skills for everyone, and EASE, which is the acronym for that. So I have some slides, of course. Which I hope you can see now. So my name is Mark Hazelwood. I work for the Scottish Partnership for Palliative Care, and I've got 15 minutes to talk about end-of-life aid skills for everyone, or EASE. And it's a public education approach that we've developed and are running currently in Scotland. So Scotland, as you probably know, is part of the UK. Just by way of context, we have our own parliament, and we have our own kind of slightly divergent, increasingly divergent approaches to health and social care. A little bit of politics. The majority of people in Scotland voted against Brexit, for example, and probably also haven't supported the current UK government. So it's kind of a distinct political and social culture with its own systems as well. That's all the politics in the presentation. So moving on. So by way of context, the Scottish Partnership for Palliative Care is a collaboration of over 100 organisations. It's basically all the organisations involved in providing and improving palliative care in Scotland. So all of the NHS, local government, and lots of NGOs, third sector as well. One of the things that we do as an organisation is also to run an informal alliance called Good Life, Good Death, Good Grief. And it's an alliance of individuals and organisations interested in improving people's experiences of death, dying and bereavement in Scotland, and particularly focused on enabling communities and individuals to support each other. And that alliance goes well beyond formal services. It's about community organisations. So, for example, we have participation from schools, care homes, arts organisations, support groups. We've had prisons, football clubs and churches all engaged with the work. And I mention both arms of our work because in developing EASE, we've drawn on the professional clinical experts in the healthcare system, but also on those links with communities as well. So what am I going to cover? I'm going to talk about who the course is for, how the course was designed, what the course looks like, and hopefully have time to show you a very brief film clip, which is one of the resources for the course, a little bit about our model for delivering the course and our experience so far and some plans for the future. So EASE, it's for anyone who wants to be able to support someone with issues they face relating to death, dying and bereavement. So it could be absolutely anybody. So people who are carers, people who expect to be carers, people who want to be better prepared to support others. And the overarching aim of the course is to enable ordinary people to be more comfortable and confident supporting family and community members with issues that they face during death, dying and bereavement. So the kind of fundamental challenge that we faced was to design a course which would deliver that aim to the broad audience that I've mentioned. So we established a development group involving SPPC staff, general practitioners, hospice educators, people from spiritual care, and we also worked with people from Edinburgh University with experience in designing courses. We used a course design methodology called ELDA. It's a structured approach. It's not rocket science, but it did ensure that we took a systematic approach to working through the design of the course. So we had our audience and overall aim, which I described. And really the next thing that we thought about was, well, what do people want to know and what do they need to know? So we had a look at what the literature says. So we, didn't do a kind of exhaustive academic systematic review, but we talked to people who are familiar with the literature, and we looked at things like review articles, particularly around research that had been done into the information needs of carers. And of course, we were already aware of the work that others had done in this area, of course, including George's work with Last Aid. We did some work with George a few years back, actually helping to translate into the first English version of Last Aid. At that time, we had a native German speaker on our staff, so we were happy to help with that. So from that, we got an idea of what professionals and support organizations felt that people needed to know. We also did an informal survey of the public to find out what people wanted to know. And that was both people who'd had experience of providing care and end-of-life issues. And we asked them to tell us anything that they wished they had known but didn't know. And we also asked people who didn't have experience and asked them about what they wanted to know. We then tried to design some clear learning outcomes for each of the key topics that came out of the learning needs analysis, which I've just described. And then we thought about the accessibility of the learning. What sort of level of complexity and detail were we trying to cover in this course? And Scotland has a national learning framework which covers sort of kindergarten through to PhD. And the EASE course is designed for people, it's on a par, it's called National 4, which is our basic secondary level of education. So when we were thinking about the kind of detail of content, that's the sort of level it's pitched at. We tried to think about how people learn. How do people best learn, and to bear in mind that different people like to learn in different ways, so a mixture of different learning methods. And then, of course, practicalities. How much time will people have? How much can people absorb in a session? How much time will course facilitators have to lead these courses? So factoring all those things in together, we ended up trying, it felt like doing a very complicated jigsaw. And there were a lot of choices and a lot of compromises. And I think the hardest choices were they were about what to leave out. Because I think always the instinct is to give people everything which might be useful and helpful to help things be easier for them. But then in no time at all, what you've designed is a master's course and nobody will come along to it. So what we ended up with was a structure of 4 modules, and each module takes 2 hours. And taking those modules together, the course covers common patterns of illness and decline, the role of different institutions and professionals in providing care, common symptoms towards the end of life, emotional and spiritual effects of illness, how family and friends can offer practical and emotional support, the importance of planning ahead, bereavement, and also it looks at the importance of looking after yourself if you find yourself in a caring role. So that was the structure, and within those modules we have a variety of learning activities. So lots of time for discussion, activities, quizzes, some PowerPoint slides, but there's not too much in the way of lecture format. Handouts. We developed some films, particularly for technical content. where we were wanting people to hear, for example, clinical information. So I'll show you an example of that in a little bit, where we felt it was important that the information was provided by somebody with clinical credibility. But we also made other films just as starting points for discussion. So we piloted the course face-to-face, made some adjustments. So alongside the design of the course, we were thinking about how this could best be delivered at scale. And we also spent a lot of time thinking about how can you deliver a course in a way which is safe, which would take care of participants when dealing with potentially difficult topics, and also thinking about how to ensure the quality of the delivery. So our model for is that we have 2 course facilitators for each course. These are people who need to be able to facilitate the course and manage a safe space for discussion and understand and accept the boundaries of that role. They have to go through a course first as a participant and then do a further course to become a facilitator. But they don't need to be experts in palliative care or indeed to have a clinical background at all. The course is designed to be delivered by ordinary people. That makes it easier to scale up, but it also demonstrates, importantly, that care of dying and bereavement is everyone's business. It's about democratizing and sharing that knowledge. And the values and ethos of the course are important to us and inform the course. So every participant on the course brings valuable experience. So there's plenty of time for sharing on the course. We're interested in the course as a way to empower communities. It's not necessarily about a course being professionally led and information being handed out. And there's plenty of space within the course for peer sharing and confidence building, which I think we believe is as important as the formal course materials themselves. A pandemic happened, so we took the course online at that stage, and my colleague Rebecca, who's on the call, took the same learning outcomes, but placed this all onto an online Moodle learning platform. It allows people to study at their own time and their own place in blocks of a week. We did a weekly Zoom session where people were able to chat, but the rest of the time people could study asynchronously. A lot of the same materials, but also added to discussion boards and things that you can do online. And similar experience to what George was describing, we've reached, I think, different people. It suits some people and not others. So experience so far, course content and design has been well received. There's been lots of demand for the course, both from the public, whom it's for, but also echoing others' experience from professionals as well. Lots of interest in becoming facilitators. And so far we've received really great feedback from the people who participated in the course, some examples of that up at the moment. And I think people seem to really value the range of activities and discussions that there are on the course. So coming finally to what next. We've developed this all within the existing resource of SPPC. There's 7 of us at the partnership, so we're quite a small team. So we're looking for more resource to be able to scale this up in essence. So our challenges are to train more facilitators, to continue with ongoing evaluation and periodic revision and update of the resources, to secure funding to scale up. There's 5 million people in Scotland, so there's plenty of need. We'll do a mix of online, and we hope get back to doing some face-to-face in the not too distant future. We've designed a much shorter pilot taster course as well, which we'd like to get out there and pilot. And then we've designed one course, but we're aware that different audiences are very different. So I think we're interested to explore variations of the course for different people in different circumstances. So I'm going to do my thanks, and if I've got any seconds left at that point, I'll show you the film clip. So I particularly wanted to thank, first of all, colleagues at SPPC. So Rebecca Patterson, who's led the development of this whole area of work, and actually created many of the nice slides that I've been showing you today. And then to Caroline Gibb, who's our community development worker with Scottish Partnership for Palliative Care, who has led the training of facilitators, and from whom I've certainly learned a huge amount about community development and also online facilitation. And also to thank Pauline Ellison from SPPC, who did all the desktop publishing for the course manual, which is there to support anyone who is facilitating of the course. And thanks also to the development and reference groups and SPPC member organizations and other funders. I'll stop at that point. There wasn't time for the film, but very happy to answer any questions.
Yeah, thank you very much, Mark. Erika, are there any questions from the chat? Erika's not. I can read one question here in the chat from Tanya. Thank you very much. What do you think about the criticism on professionalization of volunteers or medicalization at the end of life? Can you comment on that?
So I suppose what I feel is that thank goodness for professionals. And I think it's really important that the role of professional is valued. I think also what we're doing here is trying to support and build the capacity of ordinary people and communities to do other things. We heard from Marius about the shortage of professionals, but also there are unique things that friends and family can offer that professionals can't. So I think this is about building kind of one side of a partnership. And also I think in terms of what we do in the course in helping people to understand and navigate the health and social care system, I hope that we are encouraging and supporting people to be able to work in partnership, communities and the public with professionals.
We have another question. I was wondering how many people have completed the course for so far, and also do you think the course is relevant beyond Scotland? Greetings from England.
Yeah, I'm trying to, we're fairly early on in terms of the scale. So I know that we've trained around 20 facilitators, and we've probably run the course, I'm thinking maybe Caroline or Rebecca who are on the call can post in the stat there, but 60, 70 folk, I guess, early stage.
Then another question. Thanks, Mark. COVID-19 showed us that everybody could be epidemiologist. What do you think should happen that everybody could become a palliative care provider in Scotland?
So I think everyone has a role and can have a role in providing support to family and friends and community members and colleagues. We tend to use the word palliative care in a professional and service context, because I think it can get confusing if I think what we're doing in this course is not to equip people to undertake professional roles. You know, there are things which are palliative care where you need a medical or a clinical training. We're not trying to do that at all. I think you need both.
We have also some comment Mark. I think you have misunderstand Tanya's question.
Oh, sorry.
She means the process of professionalizing volunteers. I think that it's to be too much professional and not anymore volunteer. Like the medicalization of the illnesses, also the professionalization of the volunteers. Is this good? Or
so the people who in ease would be volunteers would be course facilitators. And I don't really see that as, I think what we're looking for is and what the course is designed to do is to support ordinary members of a community to do something which they are committed to and see as valuable within their community, and to do that with competence and to a high standard. So I think that's what we're trying to do. I don't think I don't see that as professionalizing volunteers. I think it's supporting people to do something which they've chosen that they want to do. And I think people want to do it they want to do it well and to a high standard, and we can help them with that. And what they're doing is not really substituting for something that a professional would be doing, I think. So, George,
I know, do we have another one question, or it's not possible? I know it's not possible.
I think we should go on with the program. If there are any more questions, people are really welcome to stay after the end of the webinar to ask any more questions. But I think we have to go on with the program first. So thanks again to you, Mark. And thank you. I would like to hand over to Jamie Woodworth, who's a PhD student at the University of Lund in Sweden. And she's going to present some work about developing capacity for caring in civil society. Welcome.
Thanks so much, George. Thank you. Just share my screen. All right, let's see. Can you all see my screen? Great. Okay, so as George said, I am a PhD student at Lund University in Sweden, and I'm based at the Institute of Palliative Care and at the Department for Gender Studies. And I just want to thank George and the EAPC for the invitation to be here. And it's been so interesting learning about what's going on in Scotland and Lithuania. I'd be so interested in taking the EASE education at some point if I ever find myself in Scotland. So I'm going to be talking today about the implementation of last aid in Sweden, which we started just this year. And we're implementing it specifically in just one municipality to start with. And the education has been implemented with the help of a diverse network of local stakeholders, including myself at the Institute of Palliative Care, the local palliative care unit, the municipality, and different volunteer organizations as well as just various interested citizens that thought this was a good idea and they want to contribute in some way. I've been using a participatory action research methodology as part of a research project on the implementation of last aid, meaning that I've been co-leading this project in the capacity of both a researcher, but also as a community organizer. And our group of practitioners and volunteers in this program have created an action plan for implementing the education. And we've also organized quite a few workshops to reflect upon the strengths, weaknesses, and future directions of last aid in Sweden. And during this year-long research phase, I've taken a lot of field notes. I've held focus groups with participants and practitioners, and this really comprises the majority of my data for this study. And interestingly, I'm a social scientist and I'm based at the Department of Gender Studies. So I'm going to be using a feminist analytical lens to be analyzing the social sustainability element of last aid. And I'd really like to shed light on the social scientific dimensions of last aid as a public health program. And here I'm going to create more knowledge about the social sustainability of public health initiatives, particularly in Sweden and the Swedish context. So the question that I'm asking of my data is, how can last aid contribute to creating and maintaining a sustainable social ecology of care in the context of the Swedish welfare state? So what have we done so far? In the fall, we were actually able to hold 3 courses. 2 of them were on site, and then 1 of them was online. I've held 2 focus groups with course participants and 1 focus group with the practitioners. And throughout this last autumn, we've also had dozens of planning meetings and workshops that have been held between all of these different stakeholders. So with people in the municipality, people in the healthcare, people in civil society, all coming together. In total, we've educated approximately 75 people in last aid. with very positive reception as indicated by the course evaluations. Furthermore, we sedimented quite a lot of cross-border collaboration that didn't exist before. So we've been bringing together people from so many different sectors in the public, talking about palliative care together for the first time. We've also received significant media attention. 3 articles have been published in local newspapers. 2 articles have been published in healthcare-focused magazines. And you can see here the title of this article in Swedish says, last aid is just as important as first aid. So as I previously said, my research on last aid is framed around how care at the end of life can be analyzed on the level of social sustainability. That is, what preconditions are necessary for acts of informal caregiving at the end of life to be possible, and what consequences come from empowering caring in the informal sphere of life. And this is a general question for the compassionate community movement as well. So many feminist scholars have concentrated quite a lot on understanding the labor put into the birthing of children, caring for the elderly and dying, and also the maintenance of social ties, the home, supportive networks, and the basic provisioning of food and other vital resources. And they've stressed that this work is the basis of any functioning society, but it's often overlooked and undervalued. Last aid is a public health strategy which aims to strengthen the capacity for caring in the informal sphere of life. Compassionate communities comprising initiatives like Last Aid also aim to increase awareness of the value of care work at the end of life and the struggles that are part and parcel to serious illness and grieving. But what does it mean to empower care in the informal sphere? And what consequences does that have for how our societies perform and think about care around the dying and the grieving? So I can, in this study, only speak really to the Swedish context, and there are several different sites and discourses of care in Sweden. But one important one to discuss is the welfare state. So the Swedish model of welfare has a very rich history. While the model was developed more than half a century ago, it still has a very strong legacy in the way that the modern welfare state works and Sweden's overall ideology around care. So the Swedish model was based off of 2 primary ideals: universalism, which means that care should be equally available to all based on need, and defamilialization. And that's a complex word that basically just means that people should be able to live independently and not have to rely upon family structures. So in Sweden, there's a very high value placed on the social, emotional, and economic independence of older persons, which perhaps shed a different light on what compassionate communities can mean in the Nordic context, where independence is maybe more important than having strong dependence on civic society. And has this changed during Corona with the rise of many mutual aid movements? You can see here a poster for helping risk groups organized on Facebook. And this is not something that my study can fully answer, but it definitely should be investigated more. There's also an important gender dimension to empowering more care activities in civil society. You can see here that over 70% of people who get government assistance for caring for a sick loved one are women. In the year 2000, almost twice as many middle-aged women than men provided care for a dependent family member in another household. And women also provided considerably more frequent help than men. And beyond being gendered, this dynamic is also very classed, with the majority of this burden being taken on by working class daughters. And as I think George mentioned before in the Last Aid presentation, a huge majority of people who take Last Aid are in fact women. So in total, Sweden is definitely actually moving towards more refamilialized care, meaning that progressive strategies for building capacity for care in civil society are becoming ever more important. And you can see that here in this graph, which shows the combinations of different sources of help available to non-institutionalized older persons, so people living at home with serious illness. And you can see here that the proportion of people that were receiving help from government institutions decreased significantly between 2002 and 2010. And then the majority is people receiving help from outside sources, family and friends, or privately acquired services. So the questions and tensions that I seek to explore in my study about last aid are how building capacity for care through last aid can contribute to creating sustainable modes of care, where gender and class dimensions of care are not made more unequal. Moreover, how do public strategies like last aid fit into the Swedish welfare state's model of care? And what does that mean for defining compassionate communities in the Nordic context? And that was all I had to say. Thank you so much for having me, and I'm happy to take any questions.
Yeah, thank you very much, Jamie, for this insight in the Swedish situation. And I think it's also very interesting to look at the gender things. I just wrote in the chat, I've been asked how many % were women, and in our multi-center study, it was actually 88%. And we were quite astonished about that, but it's like that, yeah. Erika, are you having some question for us from the chat?
I have the question, Mark, Rebecca, what % for AIS are women, please? So Jamie, I think you open a quite interesting question. Also in our Slovenian assessment of the participants in last aid course, we have had 80% of women participating in the last aid.
Yeah, in Sweden as well, I've been looking at how many women versus men have been participating, and it looks like the statistic is actually a little bit better in Sweden in comparison to this international figure, and it's around 60% that are women.
Yeah, sure, because I knew also a study from Croatia, they have around 90% of women taking care about palliative and terminally ill patient, yeah. Similar is also in AAC, I think. Interesting. The program course seems to be taken up largely by women, but most presenters are men. This is also very interesting point. We have only one woman presenting. Jamie, very nice talk, thank you. In Lebanon, patients are highly family dependent, and those without family support feel neglected. Yeah, so yeah, interesting point that women should do the work. Yeah.
I think that's actually, if I could comment very briefly, I think that's a very interesting point, because I mean, there are quite a lot of cultural differences about how we hold ourselves to family care and what that means to us. And in my focus groups and, you know, in the data that I've collected so far, a lot of people in Sweden, like, being able to live independently is the best way of showing intergenerational solidarity. They don't want to burden their children. They don't want that family care because they feel like it demeans themselves to have to ask for it. And I think that, you know, as the graph shows, like, the refamilialization of care is definitely happening in the Nordic countries. And I think that also is going to be accompanied by some sort of cultural shift in the way we think about what it means to receive care from daughters and sons versus care from healthcare professionals.
Here we have another comment. Given the massive social and cultural differences between countries, how much of last aid stays constant and how much needs to adapt and change depending on the country it is delivered in? Very interesting question. That is the topic we try to answer now with the law in the large group, because we notice that there are differences between the countries, but also some similarities. So this is now work in progress, I would say.
Yeah, I have just a short comment, because I think this will also be the topic of the next Last Aid conference in October.
Yeah.
On one hand, and on the other hand, I can say we just have finished crossing border project here in Germany and in Denmark, and we have done several workshops doing last aid course and talking to people, both practitioners and normal people, and have been talking to them about rituals and things, are there cultural differences across the board? And what we found out was that there are mainly individual differences more than there are cultural differences. But anyway, it's really important to know about the organizational differences. So in terms of the last aid courses, it's obvious that you have to know about the legislation in the different countries. And I have learned from introducing last aid in Canada that they have different legislation on advanced care planning and things in the different provinces, making it even more complicated to do that. But still, it's doable, and I'm really looking forward to the conference. So I would just love to share the invitation to the conference. But first of all, I would like to thank all the speakers. Thanks to Marius, and thanks to Mark, and thanks to Jamie for excellent presentations. Good to see you today, and I think we have reached our time limit. And if you love this sort of webinar, probably we can have another one at another time. So I just would love to summarize, and this was what we have seen today. And thank you very much. And again, the invitation, if you want to support us and become a member of our task force, just contact me, and this is possible. And of course, the invitation to the 3rd International Last Aid Conference, which is dealing with cultural diversity and palliative care. But probably you want to say something more, Erika, about the beautiful city of Maribor.
Yes, it's a beautiful city by the river Drave. It's easy reachable by plane through Graz, from Croatia, from Budapest and Ljubljana. So please, you are really welcome. And I'm really looking forward. We have opened quite a lot of questions in this webinar. Some of them we will try to answer in Maribor, and I'm sure we have quite a lot of interesting discussion, but we have also time to go to see the beautiful city and drink excellent wine with some good food. And we won't have any COVID anymore without the alphabet, okay?
Yeah.
So I wish you everybody a nice coming weekend, and take care of yourself. George, please, the last.
I would just say, if you look at the program, you can see we are really looking for diversity, and we are really going to discuss much more in detail how is it with compassionate communities and diversity, and how is it about having courses for special groups. We didn't have time for that today, but we will talk about last aid for kids. We will talk about last aid in easy language for handicapped people, and we will talk about a project which started with Siobhan in Scotland with last aid for policemen, which inspired Boris to do the same in Frankfurt and surroundings. So this will be really interesting. So I would just invite you, come to Maribor, and thank you very much for today. And I wish you a really good evening, and stay healthy. And I hope we can see you with another webinar. And if there are any questions left, you can put it in the chat. So we will still be here. But thanks to everyone for attending the seminar, and see you another time. Bye-bye.